Thank you to everyone for joining us today. For those of you who are joining us for the first time, iCourts is a community of practice whose goal is to connect people who work in the social and behavioral sciences field of neglected tropical disease. Once a month, iCourts hosts a Knowledge Cafe webinar where we provide the opportunity for community members to present on a topic of their choice to a global and virtual audience. If you have any ideas for a Knowledge Cafe, please reach out to us at info.icourts@gmail.com. And if you'd like to join as an iCourts member to stay up to date on our activities and events, click the link in the chat to fill out the Google form. This webinar was developed in collaboration with Sightsavers, who will present their work on lymphatic filariasis elimination efforts in 3 African countries, including Nigeria, Uganda, and Ghana. We will start off with a presentation by Geordie Woods and Bob Okello, followed by a 20-minute discussion period. During the session, please feel free to put in any comments or questions that you have in the chat, and we will address them in the discussion portion of the session. Please note that this session is being recorded. I will now pass it over to Geordie Woods, our session moderator and speaker.
Thank you, Varsa. And good morning, good afternoon, good evening, whatever time it is for you. Thanks for joining us. We're pleased to be here and sharing what we know about lymphatic filariasis and the work we've been doing. My name is Geordie Woods, and I'm the director for social and behavior change and water sanitation hygiene programs for Sightsavers. I'm based in the United States. And I'll be presenting today with my colleague Bob Okello, and I'll let him introduce himself, and then we'll kick off from there. So over to you, Bob.
Thank you so much, Jody, and good evening from Uganda. And my name is Robert Bob Okello. I work as the technical advisor, social behavioral change analyst, based in Sightsavers, Kampala, Uganda. I'm so happy really having this and presenting this insightful work of ours that we conducted, the assessment that we conducted in Nigeria, Ghana, and Uganda. Over to you, Jody.
Okay, thanks. So I guess today, just sort of as a brief introduction, we're going to be sharing some insights from a rapid assessment, and we're calling it a rapid assessment because it wasn't formally research, but we carried this out under what's called the ELFA program, the Eliminate LF in Africa program, which is part of a broader program that sits under the Reaching the Last Mile Fund, which is focused on elimination of onchocerciasis and lymphatic filariasis in most of Africa. It's operating from 2024, from last year through 2030. And Sightsavers, we are directly working on this program in 13 countries. But the goal of the program is to expand up to all of the 39 countries that are endemic for onco and LF in Africa throughout the course of the program. But specifically, what we're going to talk today is about the social and behavior change aspects that can really help us improve specifically the management, in particular, of hydrocele surgeries and uptake of those surgeries and lymphedema care. So we're going to kind of talk about the evidence we gathered, but also really the stories and perceptions from the communities themselves that hopefully will give a little bit of life to some of the numbers and insights that we're talking about. So next slide, please. So for us, and again, because as a function of the Alpha program, we have explicit funding to do social and behavior change work in 3 of those countries, and that's in Uganda, Ghana, and in Nigeria. And for this assessment, we really tried to have a sort of a broad reach across those countries in sort of geographic areas, but it's also sort of reaching diversity in terms of types of places that we were looking at. So in Uganda, it was in the Teso and Acholi areas. In Ghana, we were looking in Accra, Upper West, and Upper East, so sort of the lower and the upper parts of Ghana. And then in Nigeria, we were in Benue, Sokoto, and Kaduna. And that's just for this assessment. The program itself is in more places than that. And again, the focus was on hydrocele surgeries and lymphedema care. Next slide, please. So just to kind of give you a sense of where we're coming from and sort of the context of where this sits, the little yellow circle you see on the screen there is what we're going to be talking about today, but this does sort of fit in the broader scheme of things. Where we are currently is in that phase afterwards in implementation. So we're actually now taking the insights and pieces from this bit of work and have gone through a whole set of design workshops and prototyping interventions. And Bob is actually coming from the field today. He had to race back home to talk to us because he's actually out getting some of the interventions that we'll talk about briefly later up and running in northern Uganda. So that's what we're going to be talking about is this progression. But this sort of shows you where we are. Next slide, please. So just to kind of talk about, the main goal was to identify the facilitators and barriers to care. In other words, what helps people access and complete treatment for hydrocele and lymphedema care, and just to really understand what's standing in their way and why. So really, to answer those questions, we needed to kind of look at this from a balanced, sort of from a wide angle and a very narrow angle. So next slide, please. So as such, we sort of used a mixed methods approach to gathering all of this information. So we did key informant interviews, in-depth interviews, focus group discussions, and we also used sort of more of a quantitative barrier analysis approach as well. And then drawing all that together, we looked at sort of thematic analysis as well as comparative quantitative analysis alongside. Next slide, please. So I think one thing that's probably interesting to this community and for this webinar is what after the sort of the data collection in all three countries, we wanted to make sure that our analysis and interpretations were grounded in not just sort of each of the individual country teams, but sort of grounded from the perspective of our team and as a whole. So in order to do that, we convened a co-analysis workshop in Kampala just after all three things had completed. And that helped us have a much stronger foundation and be able to dive deeper into some of the key themes that emerged from that. And the other interesting thing is that we had members from the Sightsavers research team, as well as sort of the program officer field staff, as well as project management staff. And I think that having the project managers in a sort of what was traditionally sort of seen as sort of the research team activity really brought a lot to that activity, because it really helped bring different perspectives in terms of this is how we would operationalize some of these insights. So I think it helped keep it less academic and more what are we trying to drive towards, which is really positive interventions or innovative interventions for promoting lymphedema care and uptake of surgery. So next slide. And then I'll kind of get into a little, we'll get much deeper into this, but part of what happened at that workshop is we really sort of unpacked these four big buckets of emerging themes. And this is what really Bob will kind of dig into a little bit later, but the four main things were stigma, which no surprise there, but all different types of stigma, self-perceived, structural, and sort of the gender dynamics around stigma. Really looking at perceptions and perceived self-efficacy. And that's something that really came out of that barrier analysis of really understanding what the perceptions of access to services was. And another big piece that I think we really are trying to focus on in the intervention side is this provider behaviors or communication of providers. A lot of folks with lymphedema or hydrocele, there is a lot of that shame and stigma attached, and particularly when that interface with providers is such an important piece. So we're really dug into that. And then of course, there's all the other social and contextual barriers that kind of came up, and we'll dig into those more in a little bit, but those are sort of our four buckets. And then the last thing that I will present, so next slide, please, is that one of the things that we did in that co-analysis workshop was we really tried to make sure that all of this data fit into a model that we could use. And so we debated and we looked at all of the data, and we really decided that we would use this circle of care model. And some of those on this webinar may be familiar with the circle of care model. It was sort of, I think, originally formally done as a model in 2020, and from Johns Hopkins CCP. But basically, it's really looking at sort of the circle of care model within before, during, and after services. And I think that was a really good way for us to fit in the insights that we drew from this in terms of how are we going to fit that into specific interventions of driving better health outcomes for patients with LF. I guess next animation, please. So within that, really, I think for us, we really were focusing on the hydrocele patients, so uptake of people who had hydrocele, and then also lymphedema patients, so those patients who are going to need to seek continual care. And I think an important distinction that we made in our kind of model as we presented was really important: formal healthcare workers, but as well as informal healthcare workers. So CDDs, caregivers, and these peer support networks that really, I think, are a critical piece of driving that during care, before care, and after care. So I'm going to stop giving you all the theory now, and I'm going to pass over to my colleague Bob, who will give us actually the more exciting and interesting part of what happened in this research or data collection. So over to you, Bob. Thanks. And
Thank you
slide.
so much, Geordie. Thank you so much, Geordie, for setting the pace and then for that very, very, very excellent introduction to actually what we did. My task right now is to get into deeper dive into the key insights, the emerging insights that we thought would be very, important to share with you. Definitely, I must say that, there was very many insights, programmatic insights, which came up. And definitely, those insights were actually, we actually expected them, but of course, yeah. So, but now for this, for this webinar, we are interested in just picking the key, striking, and fascinating insights that we think, it can drive or we can contribute to certain debates around certain topical things. One of it is the gender dynamics, the stigma, which came up. Definitely, we know stigma was a big factor in LF patient care services and management. But still, what came out, what struck us so much was like the gender dynamics compounding the effect of this stigma. We saw the gender coming in as an effect modifier, as something which really, compounded the effect of stigma. Like, we found that, between much as both males and female experience a lot of stigma related to having those, symptoms of hydrocele, and then of course LA and then lymphedema. But what came out most strikingly is like, female patients were much more, impacted by this stigma. A case like one of the example that I can give in Uganda here, we found so many of the evidences, the insights coming out that, wherever the women patients would start experiencing the LF symptoms, their husbands would disappear, okay? They would disappear and then they would go in the neighboring villages, the neighboring sub-counties to marry or to get new partners. And that wasn't the case with men. Men's partners, like, the spouses were always with them. So we found that, much as there was stigma affecting both groups, but that was also a pointer because marriageability is, in Africa here, to be able to be married is something that we take seriously. So once that stigma or once that, condition is affecting your marriage, it's something that causes enormous psychological and traumatic, some odd disorders. So that is one of it. And then in Ghana, there was also pointers to that much as, stigma was affecting both male and women, but in terms of livelihoods, economic livelihoods, women were much more even affected by this, given the fact that in the African context, women are actually the sort of providers. They do like in markets, for an example, women selling those groceries and tomatoes and all that, there were high odds of customers leaving or skipping their commodities and buying to the next sellers who didn't have the condition. So we found that, of course, much as that, but that also showed some bit of the gender sort of it. And then finally in Nigeria, this is also to add on the example that we got from Uganda. It's contrary to what women are experiencing, men on the other side are having very stable and very good relationship compared. Like in Nigeria, there was this this statement by one of the care provider, their husbands, interviewed also carers, like people who are women who are caring for their husbands, so we would see that like for one of the women came out and said like, nothing would happen to you. We have husband that suffered hydrocele, yet we slept with them and nothing happened to them. So they continue relating with them normally and providing care to them. So we thought like, anyway, there's something that is speaking to us in as far as gender dynamics and the compounding effects of stigma related to LF condition. Yeah, so that was something that struck us, and we thought like it is something that we needed to present to you people so that at least, we have a debate about it. Next. Then other insights related to stigma. This is just like something that is the social stigma. It was experienced elsewhere and all that. But still, we found that, even the local media in certain localities were involved in that sort of like stigmatizing, practices. At first we didn't know that media would be one of the platforms for stigmatization, but that is something that came out. And really, like for an example, in Acholi, where I'm seated right now, in northern part of Uganda, there's a drama titled "The Dog Barked at the Man with the Hydrocele." It might sound something very normal to you, but a drama composed and played over the radio and all that, it would be something that is so stigmatizing. And this was cited by one of the religious leaders that we interviewed in this part of the country. And according to him, it's a very big source of shame. And if you are living with that condition of hydrocele, it is something that is stigmatizes. Wherever you are passing, wherever you are moving, people are pointing at you and relaying that drama and all that and all that. So it is something that we found like is something striking, where the local media also is involved in sort of those stigmatizing, practices. So next. Then definitely, as a result of each and every now and then you experiencing stigma and all that, we realize that at some point, their self-esteem gets crushed, and that self-esteem getting crushed causes what we call self-stigma. So definitely we found so many insights or so many evidences or so many things which came out, which pointed that, most of these patients with these conditions, women and men alike, they have that some high level of self-stigma where, you find themselves covering their legs with putting on long dresses to cover their limbs, and for men putting on big trousers to cover their hydrocele. So we feel like, that is, much as their stigma, but I think there's a pointer that, a lot of people's self-esteem is being crushed by this continuous stigmatization. And this now leads to sort of like one of the worst form of stigma, which is self-stigma, where even you doubt yourself, you don't feel like human enough, So by the time a person starts getting into that condition of self-stigma, that is almost getting into sort of suicidal tendencies. So we thought like, that is something that we definitely wanted to present in as far as stigma is concerned. Next. Then another key insight that we thought would want to present, so to add to this debate, was like, the provider behavior and communication came out very, prominently. We realized that, NTDs are actually not neglected at the global and policy level, but also in the local health systems. Even in the medical schools, by the way, NTDs are actually neglected. looking at the knowledge level even the providers. So usually wherever there's diagnostic or this LF, condition, there's lack of very clear provider communication. So lack of very clear provider communication leads to patients seeking alternative care. Okay, health workers, an example, like in Benue, the health worker themselves would advise you to come home and sort things with your kinsmen. And then at home, the kinsman would order for an oracle to be consulted to reveal the root causes of the illness. If the even health providers can now resort to that sort of referral, then that is a big, big thing in terms of provider behavior and communication. And that is the reason why we are seeing a lot of LF patients, they resort to seeking care to non-medical providers. Like they prefer the preference for traditional healers and sort of prayers and all that. And you'd see that, most of them will keep on, reciting that, I visited, I have a pastor, I visited this and all that, I visited traditional healers and all. It's because the alternative healers or the traditional healers or prayer warriors or prayer, individuals are providing much better communication compared to our formal health providers. So that is something that really struck us, and really, it was some key insights, behavioral insight that we needed to take note of that. Next. And then, of course, still related to provider behavior and communication, we thought of something came out like what we call the golden hour of diagnosis. I remember during the era of HIV, when HIV was still so much, wherever you would go for HIV testing, the results would be very clearly communicated to you that this is a chronic condition and you'll have to live with that. But in LF, knowing that it's a chronic condition, definitely, especially those with the lymphedema, during that golden hours of diagnosis, we discovered that health providers are not communicating properly to clients to make them know that this is a chronic condition and definitely you are going to live without it. What we can do as health providers to help you manage and live with it, have a better life with that condition, that is lacking. And that is why there is this constant quest for cure. If you are to look at, you find, if you are to contact most of these people with LF, you will find that there's constant quest for cure. They are looking for cure each and every, because that communication didn't come out explicitly from providers during the golden hours of diagnosis. We have an example which we got from Kaduna. Definitely there are so many, but we thought this one would be, like I went to Douala in Cameroon looking for medicine. The same person went again to Gabon looking for medicine. The same person again went to Central African Republic, Central Africa, looking for medicine. This same person, imagine moving almost in those 3 countries, looking for cure and not even getting that. So with that limited, support and all that, that leads to sort of like, some bit of traumatic, frustration with the health system, frustration with the, with the medical providers, and leaving no room, leads to now very, low health seeking behaviors, in this case, medical seeking behaviors. Next. Then definitely there were misconception still related to information, because what came out was in across all the 3 countries, the causality or the pathology or majorly what causes LF was something which is debatable. Most people really, the people that we had, we interviewed or we came in, didn't really believe that, LF is a biomedical condition which is vector-borne, which is caused by mosquito. It is actually detested. And that is why actually, there's a lot of, that's what drives the myth. And that is also what drives even people's, preference for alternative care. Disbelief in mosquito, that the people were actually disbelieving that, that the same mosquito that causes malaria is the same mosquito that causes LF. So it's something that was contested, and it's something that came out strikingly. And to us, the behavioral, scientists, it has very, enormous effect in as far as uptake of biomedical services and patient care, management is concerned. For an example, the only thing they do, they give us medicine, that is in bracket MDA, mass drug administration, give us new mosquito nets, and tell us maybe it is caused by malaria, by mosquito. So maybe that may be. So it means like, it is contested, and you would see that, most of the evidences that we are getting, like people are thinking that LF is hereditary. It is, where in families where, you have, it is hereditary. It is something which is caused by witchcrafts. Actually here, they think that it is even stepping on where a person with the lymphedema stepped is also causes, So it is a lot of, things that this belief, so contested causality related to LF. That is something that also we found like, something which strikes us, and in designing intervention, definitely we are thinking around that. Next. Then, of course, other insights which also we wanted you people to know that, definitely were fear related to death, pain, and complication. In the Upper East in Ghana, I think I was there in the Bolgatanga, we really got some myth within the community, like where that, if you have any swelling, LF presents with swelling of the genitals, swelling of the limbs. So wherever you have any swelling, there shouldn't be any sharp thing cutting that swelling. And when that sharp thing cuts that swelling, the likelihood of you dying is there. So you find that most men actually were fearing to go for hydrocelectomy because of that fear that, based on that belief that when they chop that swelling, they cut it, you are going to die. Not only men fearing, but even their close family members, because other men even would present into the surgical ward and they will come and be convinced by their family members that I think you are our health, you are a bread provider, so we don't want you to die. And they were being even forced by the family members not to go, with the fear that, their breadwinner most likely, if it goes through the hydrocelectomy procedures, most likely is going to die and they're going to lose their. Then, more fascinating, where I am right now in Acholi and in Teso next door, we found that, much as hydrocele elsewhere in other parts of the country or in other parts of the world is something which is detested, something which is, there's a lot of, but historically here where I'm seated, or in the next region where we're also implementing LF projects, there is this historical view that, hydrocele is a form of social status, it's a pride, is a status symbol, is a symptom of masculinity. So that really is something that at first we were here, but really that came out, and that would think like, why would somebody get pride in the swellings of the genitals and all that? But anyway, that is what is society perceives it. So it is not all negative. In some parts of the world, it is positive. So Bob here carrying big hydrocele would be highly, respected. And in case of position of power, I would be the first to be, to be very elected as, into the leadership because I'm having that hydrocele. So fascinating, so unique. But anyway, that is the kind of the world we live in. Anyway, next. Then, of course, other health system problems related to resources, infrastructural constraint, then financial barrier, especially in Ghana, where the health system, like in Uganda here, access to health services in public health facilities is free. But in Ghana there, it wasn't. So the cost attached to hydrocelectomy really was driving men, and then they couldn't access those services. So that was it. So, and then next. And then, of course, just to run through, just as concluding presentation, as to run through the key insights which came from the barrier analysis. We did the barrier analysis for the doers and the non-doers. The doers were actually men who had already had history of hydrocele, and they had actually gone through hydrocelectomy. And non-doers were actually men with carrying active hydrocele. So for the key enablers for the doers was financial aid, like in countries like Uganda, where, it was free, and then social family support, and then medical advice, pain relief, desire for normalcy, and then for barriers for non-doers was actually lack of funds. That is, I give you an example of Ghana, transport issue, fear of complication, absence of support, discourage the surgery uptake. And then definitely the perceived benefits generally was improvement of health, the pain relief, the dragging pain, and then work resumption, people would resume work normally. Then social acceptance for husbands who really had already a problem in their marriages, they already, having their, getting their sex life and marital life getting back, and then emotional stability, and then post-surgery, and then of course other common fears and risks, pain during recovery, fear of death, that one in Ghana that we got, and then of course post-surgical complication, is not all good, like after getting surgery, probably 1 in 100, you sometimes you get into the condition where you get those adverse events as a result of those post-surgical infection and all that. So, and then of course community influence, overwhelmingly generally there was community approval and encouragement from family members, friends, and local figures promoting hydrocell uptake. Next. Finally, I think so, community and social norms. There was very high approval of hydrocell. For the doers, it was generally 100%. For the non-doers, was 90%, which is significantly high. So based on the barrier analysis was based on the health belief models. So looking at those perceived risks, perceived benefit, and all that, and then perceived. So all this, we found that, there were actually very high level of approval, high approval level, and then of course support, minimal disapproval, and then cultural permissive environment, and even religious by the permissive environment. So I think basically this is what really the main insights which came out of that we thought like would present. Over to you, Geordie, to finalize. Yeah.
Thanks, Bob. And I know this is a lot of information, and we wanted to keep our presentation relatively short so that we could open it up for discussion and conversation. And I know that folks on here have lots of experience that they would also bring to the table. I did respond to that. Yeah, cost was one of the biggest barriers, certainly for uptake of hydrocele services. But kind of coming back to where we started, that was really just a snapshot of the really fascinating insights that came out from the 3 country sort of rapid assessments. And since then, over the last 2 months, we've run these design and prototyping co-creation workshops, which have been really, really great. We've done them. Most of them have been residential workshops where we've brought people from the program, as well as people from the community with LF, community leaders, really everyone who you would expect to be part of a co-creation workshop in developing interventions for specifically uptake of hydrocele surgery, as well as really focusing on that, community care piece. So now we are in this phase of implementation, and I thought that we'd just share again just a snapshot of some of the things that are coming up and coming out of what all of those insights have led to. And I think, again, really leaning into, as Bob mentioned, fascinatingly in northern Uganda, that we could actually use pride. There was a sense of pride in hydrocele, and what do we do with that emotion versus sort of the stigma piece. So really trying to navigate our way through what that looks like in peer support groups and in direct implementation with providers. So next slide. And I should also say that this is sort of like real time we're talking about this. So we're like at the phase of iterating and really trying out some of these prototypes that have come out of this. So the goal basically was to develop culturally tailored social behavior change interventions. And I should also say that sadly, given the funding climate, I mentioned this before we started the webinar today. It's a difficult time for international development and NTDs in particular. And the Alpha program, the specific piece for social behavior change, was supposed to be a 3-year program, and we have since lost the funding. So we're really trying to do everything we can to get out these findings for the 3 countries where we're implementing, but also share this broader so that we could sort of get the most leverage out of all of the work that has gone into this so far. So I say all of that to say that we're really trying to integrate these insights and some of these proposed approaches and prototypes into the routine health services as really main parts of sort of a health strengthening part. So as such, we've really, in those design workshops, we really engaged lots of local leaders, religious figures, and VHTs or community health worker as part of these creation exercises. So, and as much as possible, we'd also like to be able to sort of say, hey, this is, how are we doing in terms of moving that needle of some of the psychosocial support and maybe even building of uptake of some of the hydrocele surgeries for people that need it. So those are sort of our recommendations. But the next slide, I'll share with you a couple of the interventions. So some of the sample interventions that have come out, and and perhaps Bob can maybe expand on some of them. So, right, for example, in Uganda, we were doing inclusive champions and peer support. So neither of these are sort of new things. The inclusive champions really are, pulling in advocates. They're not just people who are an LF patient, but some of those religious leaders. So a lot of these folks that are really advocates for people suffering from LF, but also other skin NTDs. So really, people who are suffering from chronic disability. So that really having those as mouthpieces, and then paired with these peer-led models where we've got, I think in Uganda, the term is expert patients. So the patients that really have gone through the system and are able to support other patients. The other big piece that has been a really huge focus for us is this IPC, or interpersonal communication. Again, this is a much broader difficulty within the context of health systems, not only on the African context, but I would even say in the context here in the USA. But really making sure that training is integrated into existing training approaches, but also that there is some perhaps bespoke training around how to talk to people with conditions like lymphedema. Alongside of that, we're again sort of like a 365 approach, really looking at some of these targeted media campaigns in specific areas that came out from in Ghana, Nigeria, and Uganda, where there really was a lot of fear around, or just a lot of cultural myths around what lymphedema and LF is. So we're really having some targeted media campaigns to up that ante in terms of communication from the program. And then the last part that we're really championing is using different school platforms. So the school platform is one, and different social media platforms. So this is, out of those co-creation workshops came, I would say probably 50 or 60 different ideas. And we've really kind of honed into basically this sort of set of 4 and iterations of these, or rather 5 types of interventions that are being prototyped and tried out right now. And the idea is that these will be launching as we speak. Like I said, Bob is in the field doing that now. And we're trying to push this out and then share feedback in the 3 countries, but also would like to share this with other countries who are working on LF programs, so that hopefully that this can be much broader than just the 3 countries that we focused on. I think that's the last slide. Do we have one more? Yeah. So, we've left a little time just to have some conversation with everybody, and wanted to open it up for questions, comments. But again, really thank you so much for having us and letting us share these insights. So yeah, I already see one coming up. So thanks, Allison. I'll read the question. A couple of questions. 1, how do you identify champions? Are there particular criteria you look for? 2, are these individuals trained or guided? For the IPC providers, so important. Seems to me the IPC needs to be broad across all diseases, conditions with health system. Was the IPC training only related to NTDs, or was it broad across other conditions? Yeah, I'll start backwards, I guess, and then I'll pass over to Bob. So thanks for the question, Allison. Yeah, IPCs, it really is, I think it's a hard nut to crack. And I think that it is across all of the diseases. I mean, certainly that was recognized that's a big piece. I think that in the context of this program, this is training integrated into specifically some of the NTD pieces. But like I said, I think we're really trying to find opportunities to build it into the broader spectrum of, basically, public health, public nursing training as a whole. So I think that we're looking at a couple of different approaches, like I said, so built into national trainings, but also some bespoke training. Like, for example, if there's a mass drug administration, adding that as a module in the MBA curriculum, even if it's not specifically focused on lymphedema, for example. I don't know, did that answer kind of your question, Allison? At least the second part?
Yes, thank you. I can
Sure.
put my voice on and say thanks, Geordie. Yeah, no, that's great. Thank you.
Sure. But then, yeah, I'll turn over to Bob because he's really part of the champions piece.
Oh, thank you so much, Alison. That is very, very wonderful question. Like, your question is, how do you identify champions? Are there particular criteria you look for? Are these guided? Are these individuals trained or guided? Very interesting question, Alison. So are there very, particular criteria we look for? Yes, there's a criteria, but of course, like, eligibility, like we are not very, 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 very strict on the eligibility. But who are these champions? The reason why we are using these inclusive champions is to address stigma, okay? That is the piece to address stigma. And then who are these inclusive champions? These champions are actually expert clients or patients who have shown resilience to stigma. They have shown good practice in disease management. And of course, they also have powers to influence, okay? So we are picking patient, expert patient clients as part of that, but also we are picking influential community members who have the intention positively to address, for example, in Northern Uganda here, even we are picking health providers by the way. We have health providers who are out there, and we are also intentionally also targeting health providers because we know they are a trusted form of, sources of information. So we are picking influential people, but of course having a mix, grouping where we have the patients, then of course people who have the powers also to influence, okay, who have the positive will, the goodwill to actually tackle stigma related to LF or disability, okay? So I think that is how I can answer this. But of course, we are also trying to, contextualize it. The criteria is we're a little contextualizing it. We are not trying to make it a little rigid, in eligibility. Thank you.
And Millicent, I see your question. Maybe you can expand a little bit in terms of what you mean by scale up of the programs itself.
Thank you so much. My name is Millicent. I'm from Kenya. I'm joining from a small town in Kenya called Homa Bay. We just recently concluded one of the neglected tropical diseases. As I've typed there, we were literally putting it under gynecological conditions, but it's stemming from NTDs, and that female genital schistosomiasis. So I've learned a lot. So from this presentation, I was just wondering because LF could be affecting more of what the study was targeting. That is the scope of the study. So if the project is supposed, that is the project which is just being presented. So if it was supposed to be scaled up kind of like a wider population, what aspects would you have done differently? Thank you.
Thanks, Millicent. I'll give it a shot, and then maybe Bob can add to it. Yeah, I mean, I think the insights that came out of this were obviously very specific to the questions that we asked around, hydrocele and lymphedema. But that said, even in the insights, we didn't share a lot of it, but a lot of stuff came up around other skin-related NTDs, so borrelial ulcer, leprosy, and beyond that. So any kind of conditions that cause morbidity, I think these insights would apply to that. So I think if we were to sort of scale this up, or at least scale the rapid assessment piece up, I would say that we would just be a little bit more inclusive around different types of medical morbidities related to NTDs or other conditions. But I would venture to say a lot of the insights would remain the same. I mean, one thing that I will say, I was I was impressed with our team. We managed to do these three assessments in all three countries in basically 6 weeks. I mean, so they really, when I rapid, it was incredibly rapid in terms of qualitative research. But I mean, we really mobilized team. But I think we got a lot because we were able to do it within a condensed period of time, and it really helped us to really start to look at across within country, but also across the three countries. So thanks for that question.
Thank you. Thank you so much, Geordie, and thank you so much, Millicent Ouma. Ouma is just a Luo like me. I think it's just next to me here in Kenya. I think here is a wonderful question as well. What aspect would if you were to scale up, what aspect would you change? To me, like, definitely I wouldn't change it, but I would still encourage for integration. Like, like we have looked at stigma. Stigma has a mental health component, okay? So if we are to scale up, I would think that there would be an intentional partnership with the mental health partners, okay? Partnering with bringing in the mental health, partners in a partnership. So like in Ghana, we have the basic needs. In Nigeria, Geordie, we have the CBM. In Uganda here, definitely we are still. So really, if we are to scale up, we'd think that, how do we bring in this, the mental health partners who are within the domain of mental health, because addressing stigma, and it has an aspect of mental health component. So how do we piggyback on that expertise in mental health and all that? So I think that is actually I would think, yeah. So yeah, that's my answer to your very wonderful question, Millicent. Thank you.
Thank you so much, Bob.
Okay, here's another one other challenge with LF management now is the knowledge gap, is morbidity management. Most times the focus is on MDA coverage with little or no attention paid to disease management of the disease, including mental health aspect. I think, yeah, no truer words have been spoken. I think that's particularly in this sector of neglected tropical diseases, that is going to be the big challenge for the sector, moving from the clinical sort of NDAs and LF is a perfect example, because so many countries are really reaching that elimination threshold from a mass drug administration perspective, but that we're leaving back all of the patients that still really need that care, and again, elimination is not eradication. So that piece is the hardest part, I think, for this. And I think it's unsolicited in part, maybe not part of this question, but one of the other parts of that was in that rapid assessment, really, in different even communities in Ghana, for example, when we did the co-creation and then sort of rapid field testing of some of these prototypes, was really looking at who if you went to the hospital, for example, and just didn't have a great experience for whatever reason, and just were sort of discounted or just kind of turned away because of your condition, who in the community do those people go and talk to? And interestingly enough, a lot of, and maybe for a good reason, a lot of the folks we talked to, certainly in Ghana, were the CDDs. So these CDDs who had participated in some of these in the MBAs were one of the really most trusted people that they would go to. So they were, and interesting, some of the CDs actually then referred them to traditional healers, which maybe isn't ideal, but that really was interesting, kind of finding who the people that we really needed to focus on that knowledge gap was, right? Because it actually wasn't the healthcare systems that folks were looking to get more information from. Any other comments, questions, similarities from various places that people are working. There's a question from Alexandra, and I'm going to maybe point this one at you, Bob. Could you maybe elaborate on the structural stigma? Is this linked to knowledge gap in morbidity management of LF?
Oh, I think, did we talk about structural stigma? Definitely. What we've also in our barrier analysis in the health, using the health belief models, we also interrogated where there are other norms. When they talk about norms, it has also an aspect of laws, policy, community policies, or norms, which are barriers to know. So I think nothing striking came from the angle of structural stigma. I must be honest. I looked at this, the data speaking to me, the data that we collected. Actually, nothing so much prominent came from the angle of structural stigma. What majorly came out was like the social stigma, the self-stigma, and then the self-stigma, and then affiliate stigma. The affiliate stigma where the carers or even the partners faced some form of stigma, but not structural stigma. Yeah, thank you.
Awesome. And then the other question is, what were the most surprising barriers for non-doers of hydrocele surgery? Bob, you're probably more familiar with that data than me. What were the most surprising barriers for the non-doers?
The most surprising barriers for the non-doers for hydrocele, to me, I don't know, was specifically when I was in Ghana, what the most striking barriers for the non-doers in Ghana, especially in the Upper East, was this fear, this notion that, or this belief that, when you have any swelling on your body, LF symptoms presents with swelling of the genitals, swelling of the limbs. So whenever you have any swelling, you shouldn't be exposed to any cutting by any sharp object. If you do that, you will die. Okay. It was very fascinating to me. That is not in Uganda here. Definitely we had fears, but that was very fascinating to me. And then of course, something which was also fascinating was like, among the non-doers was in Ghana, there's this artisan mining, artisan mining. So the men who are mining, who had hydrocele, actually didn't want to go for hydrocelectomy because the healing period would take longer and would really prevent them from making money, so from working. So that was also something really, which actually, and even also in Uganda, also a bit of that, men were only waiting for less, less like in farming season, definitely they wouldn't want to go for that because it would interfere with their, that was that link between what I got from Ghana with the artisan miners and then what we found from the Ugandan sort of agrarian community. That link is also something which strike me as one of the barriers which are linked to non-doers here. Yeah, thank you.
Yeah, definitely the financial cost, both of sort of financial cost of missing out on work and financial cost of accessing the services was a big piece of that. Another interesting question from Deborah on the traditional beliefs piece. That's something that actually has come up in a number of the co-creation workshops, and I think where we've really landed that addressing traditional beliefs versus sort of the biomedical and the conflict within was, as opposed to one or the other, is that a yes and or that because the idea, the traditional beliefs leaning into sort of the spiritual part of spiritual healing, but also sort of the making sure that you've got good biomedical care, and so that's one of the things that we were really working on. And in Ghana was a great example because they actually have really engaged the Traditional Healers Society there, and making sure that the traditional healers are able to sort of have the biomedical information and can refer when appropriate, but also that recognizing that the sort of the spiritual beliefs carry some weight in terms of both things can be true at the same time. And so I think that's what we're trying to lean into with kind of making sure that that it's not like oh, these people are wrong or these people are wrong, but both things can be the same at the same time. Yes. And another comment from Ute, totally agree. Training of CDDs, CHVs is really important. We have now 3 projects in Ghana, Tanzania, and Cameroon, and built more radio management in local settings to include training. Yeah, that's great. It'd be great to, learn more from you about what has worked and what hasn't worked in those morbidity management trainings. Yeah, like I said, please, and I know that we're coming a little bit to the close of this webinar, but I think our emails will be shared or have been shared, but certainly reach out to us. We'd love to talk to anyone more about the work that we've done so far and the work that we're doing. There they are, right there. And I know, at least I see on my screen that there's been like a poll about today's session. So I know that the iCords community would really greatly appreciate if everyone that attended would fill out the poll. And of course, it was wonderful. No bad reviews. But yeah, and there's a few more minutes if there's any other questions. But other than that, I'm sure people have other things to do with their day. So thank you very much for attending, and look forward to hearing from some of you if you want to talk more about it.
All right. Thank you so much, Geordie Woods and Bob Okello, for presenting at our Knowledge Cafe today. If you would like to learn more about the work that Sightsavers is doing and about the presentation today, please feel free to reach out to Geordie Woods or Bob Okello. Their emails are down in the chat below. If you would like to attend more Knowledge Cafes like these, please sign up as a member using the link in the chat. And thank you all for attending. So please take a moment to fill out the Zoom poll before you leave if you haven't already.
Thanks, everybody.
Thank you. Bye-bye.
Take care.
Thanks, Geordie. Thanks, Bob.
Thanks, Allison.
Nice to see you.
You